Good evening and welcome to the CCTF for this evening. I'm Christina Kao. I'm going to be the moderator and we're going to go ahead and get started. I just have a few introductory slides to start off with. Okay, so tonight's topic is going to be lung transplantation and COVID-19. And like I already said, I'm Christina Kao. I'm the moderator for this session and I'm at Baylor College of Medicine. We are joined by two of our fellows, Sami, Bashour, and Maniar, who are fellows here at Baylor. And then we're very lucky to have two experts on lung transplantation join us, Dr. Parulekar and Dr. Hachem. I would like to thank the ATS CCCTF for inviting us to give this presentation, including the chairs and all the staff at the ATS. These are our disclosures for today. And you can earn CME and we will post that link. But for today, our objectives for this talk are to describe the timing and indications for referral to lung transplantation in patients with COVID-19 infection, to describe how prior lung transplantation may affect the severity of COVID-19 infection, and then to discuss the management of lung transplant recipients with COVID-19 and the potential long-term effects on graft function. Just for your information, they have already completed a large number of CCCTF webinars, and those are available for free for everyone on the ATS website. And as you can see, that they have already discussed a number of topics relating to COVID-19. And as I said, these are available on the ATS website, and you can search for ATS COVID Forum, or you can follow this link. Upcoming topics in the next few weeks include vaccine development and immune responses in COVID-19, PE and thrombosis in COVID-19, and other topics. And we'll post this as well, but please complete the evaluation to claim CME, and there's a QR code link as well. So with that, we're going to go ahead and get started with our presenters. Our first presenter is Dr. Sami Bashour, who is a second-year fellow at Baylor, and he did his residency also at Baylor. And he's going to present a case of a patient infected with COVID-19 referred for lung transplant consideration.
Can you all see my screen okay?
Yes.
All right, thank you. So again, my name is Sami and I'm a second-year fellow at Baylor, but we'll just get started with our case today. So we have a 31-year-old lady, no significant past medical history, who at the time of presentation was pregnant, 28 weeks and 5 days. She showed up at an outside emergency department because she had been complaining of roughly 1 week of dry cough. However, in the 48 hours before her presentation to this ED, she said that she started having spiking fever somewhere to 103 Fahrenheit, as well as worsening shortness of breath and dyspnea on exertion, where she was no longer able to get up from bed and even make it into the bathroom without feeling short of breath. At the outside hospital, at the outside ED, she was found to be COVID-19 positive, but also her rapid strep test was positive as well. She started having increasing oxygen requirements. When she initially presented, she required 7 liters nasal cannula, but very quickly she was escalated up to 15 liters on a non-rebreather mask. They started her on azithromycin, gave her some betamethasone for lung maturation of the fetus, and then transferred her over to Texas Children's Hospital for higher level peripartum care. At the time that she got to Texas Children's Hospital, the outside records note that she was visibly dyspneic and tachypneic. She had a significant work of breathing. They switched her over to high flow nasal cannula, and that did initially improve her work of breathing. They started her also on ceftriaxone for her group A strep pharyngitis, and then initiated COVID-19 treatment. So she got a total, while she was at Texas Children's, she got a total of 5 days of remdesivir. a single transfusion of convalescent plasma, and then a total of 10 days of dexamethasone. Unfortunately, 4 days into her hospital stay at Texas Children's, her respiratory status acutely worsened and she had to be emergently intubated. Following intubation, they took her straight down for cesarean delivery, and she delivered a baby girl healthy, and per the outside notes, things were going well with her daughter, but at 29 weeks and 2 days. Unfortunately for the patient, though, after her surgery, she had worsening hypoxemia and could not be extubated. So on hospital day 14, they finally transferred her over to the Baylor St. Luke's Medical Center for higher level adult care at this point. At the time that she arrived to St. Luke's, she had a fever of 100.4 Fahrenheit. Vitals were okay. The blood pressure, 99/55, that was on an arterial line. Her MAPs were in the low 60s, but she did not require pressors at that point in time. As far as her vent settings, she was on CMV, a tidal volume of 300, rate of 26. Her PEEP was 9, and her FiO2 at that point was 60%. The pressures at initial presentation, her peak airway pressures were 38 centimeters water, her plateau was 37, and at that point in time, her PF ratio was 267. On exam, she was intubated, sedated on hydromorphone and propofol. She did require some midazolam as needed. Cardiovascular exam was regular rate and rhythm, no murmurs. On auscultation of her lungs, there were coarse breath sounds bilaterally. Her abdominal exam, notable for her recent C-section, but the wound was healing well. No pitting edema bilaterally, and pulses were palpable bilaterally as well. Her initial laboratory values were generally okay. Her CBC, notable for anemia, hemoglobin was 8.1. Her BNP was acceptable, creatinine was 0.5. She did have a little bit of elevation of her ALT and AST, those are 40 and 75 respectively, but they really did not get significantly worse than that throughout her stay. Her inflammatory marker, CRP, was elevated, LDH was elevated, but everything else was relatively acceptable. This was her chest x-ray at the time of transfer to St. Luke's. The right internal jugular vein cannula that was placed, or catheter that was placed outside. You can see the diffuse bilateral airspace disease, but that's her initial chest x-ray. Unfortunately, throughout her hospitalization, while in the ICU at St. Luke's, her oxygenation continued to be a major problem. At that point in time, on hospital day 20, she was on inhaled epoprostenol, deep sedation, and then paralyzed with cisatric curium. They started proning her as well. And by hospital day 25, because vent weaning was going nowhere, they ended up, ENT performed a tracheostomy. By hospital day 25, she had already had 3 negative COVIDs at our system. So she had had 2 negatives after she first arrived, and then 1 more negative COVID before the ENT team would perform the tracheostomy. Unfortunately, she continued to have very difficult oxygenation. Hypoxemia was worsening. As soon as they tried to wean down paralytics, her oxygenation would get even worse than before. And the next thing that I'll be bringing up is a poll to ask everybody here. In terms of, given this worsening hypoxemia, given this lung compliance issue. So her airway pressures went from the high 30s to the high 40s. So at that point in time, would you refer this patient for consideration of a lung transplantation? I will also say that her PF ratio went from the 250 range to below 100 by hospital day 25. And I'll give the poll.
Yes, so the poll is active and you can please respond.
I'll give it a little bit of time, but from what I can see, it's kind of split almost evenly at this point in time. A little bit more yeses than no's, or I don't know.
Okay, so we have 43% yes, 24% no, and 32% didn't know.
Well, ultimately, what the MICU team did do was consult the lung service team. On hospital day 28, so 3 days after her tracheostomy, when the lung transplant team, when we did evaluate the patient, by that point in time, she had already been intubated for roughly 24 days on deep sedation and paralytics throughout this whole period of time, significant deconditioning. because of how long she had been intubated and bedbound. And unfortunately, those issues precluded her from an active listing in an urgent or emergent setting. However, fortunately for the patient, she did have only single organ dysfunction. Her kidneys never took a hit. Her heart never took a hit. She never had any thrombotic complications from COVID-19. So it was just a lung issue. And so the recommendation from the lung transplant team at that point in time was to consider extracorporeal life support. And so the ECMO team did come to bedside, and it was a whole multidisciplinary approach to the consultation. But the final recommendation was to proceed with VV ECMO cannulation at bedside. And so she ended up having a right femoral vein inflow cannula placed, and then a left subclavian outflow cannula placed. And per the discussion at that point in time, we were thinking that it could be as a bridge to transplant. So if the oxygenation improves with ECMO and she's able to come off sedation, she's able to improve her physical abilities and strength training, then if she still needs a transplant, she could be evaluated fully then. However, or in a better case scenario, if she seems to recover, then she won't need it altogether, but ECMO would be the right next step for this patient. Luckily, over the coming 8 days, so by hospital day 36, with the support of the ECMO, she was able to be weaned down to trach collar. And at that point in time, she was still having significant flow requirements on ECMO. So I think her flows never came down, somewhere between 4 to 4.5 liters. Her sweep was down to 1.5 or 2. However, because of where her cannula sites were, the physical therapy was really limited. And so the decision on hospital day 36 was to take her back to the OR for a cannula exchange. And so she had a right internal jugular Avalon cannula placed so that she could improve her mobilization with physical therapy, given the perceived prolonged ECMO needs. Ultimately, I'll show her chest x-ray. This is after ECMO cannulation. You can see the left subclavian, and then there is a femoral cannula as well, but it's kind of hard to see on this chest x-ray. But you can see that the dense consolidations bilaterally had significantly worsened from her admission. And then this is the chest x-ray after she came back from the operating room for the Avalon cannula that was placed in her IJ. Luckily for her, actually, she improved. She was able to stay on trach collar. She was working really well with physical therapy down in the ICU. And finally, on hospital day 42, she was decannulated from VV ECMO successfully. 2 days later, she was transferred out of the ICU altogether. And although the lung transplant team continued to follow along throughout her hospitalization, because deconditioning and strength training was still something that needed to be worked on, the recommendation was to discharge to an inpatient rehab facility, work on her physical therapy needs before coming back as an outpatient to complete the full lung transplant evaluation as needed. So she was ultimately discharged and was doing quite well. This is her chest x-ray. This is right before, I think 2 days before she was discharged from the hospital. There are still some bilateral abnormalities, as you can see, however, significantly improved from initial presentation at St. Luke's. Throughout the hospitalization, I will say that her right hemidiaphragm did become elevated. We weren't able to work that up fully during the admission, but it will be something that'll have to be taken into consideration when she comes in as an outpatient. Before any transplant can be considered further. And I think that's, from my standpoint, that's pretty much the case. So I'll turn it over to the discussion at this point so that we can kind of go over COVID-19 pneumonia and ARDS, and then when to call the lung transplant team in a COVID positive patient. And then maybe more generally, when is ECMO the right thing for a bridge to transplant versus just a rescue ECMO for those severely hypoxemic respiratory failure patients that don't seem to be getting better with anything else. Thank you.
Thanks, Sami. Our next speaker is going to be Dr. Amit Parulekar. Dr. Parulekar did his residency and his fellowship in pulmonary and critical care at Washington University, and he also was trained in lung transplantation there. He is currently an associate professor of medicine at Vanderbilt School of Medicine, and he is the medical director of transplant at Vanderbilt University Medical Center. He is going to talk to us about considerations for transplantation of patients with COVID-19.
Okay, you can see my presentation slide. Good, all right. So that was it was a really good presentation by Sami, and I think it's something that we as a transplant team are seeing a lot of, and I suspect obviously there's much more COVID in Houston than there is in Nashville, but certainly the type of consult is very similar to what we see. And unfortunately, to foreshadow a little bit, I'm not going to give you a lot of great answers here, just maybe more questions to think about. Certainly don't claim to be an expert discussant, but I think what you'll take away is that I think there is, at this point at least, a very limited role for lung transplantation in COVID, and it fits a very, very niche group of patients. And so before I go on, you can hear me all right? My sound is good enough? Perfect. All right. So so these are this is a case report or a case series out of China on really kind of the first 3 transplants for COVID-19. These were patients that were transplanted in February and March of this year. And this is their imaging, just so you can kind of see and compare it to some of the patients that you've seen in the hospital. So patient 1, this is 1 day prior to lung transplant, essentially pretty severe lung injury here, whiteout on both sides. The CT 5 days before transplant doesn't maybe look quite as bad as you thought it would look. Patient 2, kind of similar findings, although I would say that their CT looks a little bit more fibrotic, at least on the cuts that we get. And patient 3, similarly, X-ray looks a little bit better, but again, more fibrotic appearing here on this imaging. So when we look at the characteristics of these patients, I'll highlight a few things without going into too much detail here. Again, 3 patients from China, all men. The youngest patient was 58. They did 1 66-year-old and 1 73-year-old. I'm not sure I would advocate for transplanting either of those patients off ECMO if you were to get them. We know that ECMO transplantation in the acute setting likely has slightly worse outcomes, at least, than non-ECMO ambulatory patients, and that's when done at high volume centers. And we also know that age in conjunction with ECMO has worse outcomes. But if you just look at these patient characteristics out of interest, you can see that the majority of them got transplanted about 6 weeks into their illness. All 3 of them were on ECMO. The first patient was on VAV ECMO with 5 liters of flow, the second patient on VV with 3.5 liters of flow, and the third patient on VV with 4 liters of flow. You can see that patient 3 had a lot of comorbidities also, which I would probably steer clear of in a 73-year-old transplantation off ECMO. And then in terms of their outcomes, the first patient is actually an interesting transplant. He was slated for a double lung transplant, ended up getting a right single lung transplant, and while doing the left side, arrested. And then they transplanted a heart, which I assume they got from the same donor, which was a little difficult for me to understand. Nonetheless, that patient continued to kind of diffusely bleed and died on post-op day 1. The other 2 patients survived at least to 22 days and 12 days post-transplant. There's a lot of factors here that lead me to believe a prolonged survival in patient 3 may or may not be possible. So then what you see after the initial publication is you see kind of a spattering of predominantly press releases. And so as most are probably aware, the first COVID-19 transplant in the United States for COVID-associated ARDS was done at Northwestern. They've done a couple of transplants, University of Florida, Herman in Houston, amongst others. Now, there is probably some reporting bias in this. We don't know everyone that's been transplanted yet, and the early transplants, how they were coded in UNOS, we'll have to sort out. We're of course not any different about press releases. We performed the first heart-lung transplant for COVID, at least first successful heart-lung transplant in the world, and that was earlier this month, or actually late last month. And so I think, you know, the considerations for Sami's case and all cases well, I think there's really two different things to look at. The first is what we're really talking about, what Sami's talking about in his specific case is COVID-associated ARDS. We have historically done transplants in ARDS, although it makes up a tiny minority of transplants. And so we figured out some things related to pneumonia-related ARDS and maybe even influenza-related ARDS in terms of what may and may not work. But again, it's not a major indication for transplant in and of itself. And so I think when you're looking at these patients, there's really two things to look at. One are the COVID-specific considerations, and one are the non-COVID standard transplant considerations. And I think sometimes we look a lot at the COVID and forget about the standard kind of indications and contraindications of transplant. And so when you're thinking about transplanting these patients, you want to be sure that they meet your center's criteria for transplant independent of COVID. That means, what are their comorbidities? What's their physical rehab potential? Do they have other organ dysfunction? Do they have appropriate social support? Is their BMI prohibitive? How old are they? All of these things taken in conjunction with each other. Have they had a recent malignancy? Things that would otherwise make you not a good transplant candidate if your disease was IPF or if your disease was COPD, still make you not a good transplant candidate if your disease is COVID-related ARDS, and maybe even to a greater extent, meaning perhaps the number of relative contraindications in the acute setting for transplant ought to be fewer. When we look at COVID-specific considerations, I think there are several things to consider. The first is, what's the timing of transplant? And Sami's case brings up, how long do you give people to recover? What's the appropriate amount of time to recover? I argue that that's at least 6 weeks. Some people say 4 to 6 weeks. I can tell you that our ECMO runs here for COVID have been much longer than our standard ARDS ECMO runs. They've been longer than influenza-associated ECMO runs. They've also been much more difficult to manage than those other patients. We've had to use more neuromuscular blockade and heavy sedation than we often have to use in these settings. We've had people on significant cannulation setups, including a couple of patients that had 2 full circuits in, so two femoral drainage cannulas and 2 inflow cannulas, 1 in each IJ, flowing at 8 liters. And one of those patients recovered to discharge from the hospital after more than a 2-month stay, who someone might have considered otherwise for transplant. So we don't know yet what's the appropriate amount of time to wait and to allow for recovery. There are some questions that arise about the transplant consent process, and should you transplant people that can't give first-person consent? And the reason that's important might not be as important if you've previously discussed transplant with them. So if you have somebody with pulmonary fibrosis that ends up getting an acute exacerbation and you have to bridge them to transplant, at least that's been discussed before. Here you have people with an acute illness that the physical and mental recovery from that is already significant. You can imagine not knowing you were getting a transplant, waking up with the transplant, what implications that has, how long is your recovery going to be, what limitations are you going to have in the rest of life. And I would advocate that first-person consent is probably necessary. What to do with your COVID PCR? Does it need to be negative? Is that really what you're looking for? And then I think center experience is important. I think that this should mostly be done in large volume transplant centers that have significant experience with ECMO bridging, especially in the acute setting, not like a ECMO bridge for CF or pulmonary fibrosis that's an ambulatory sort of bridge. I'm talking about an ARDS acute setting bridge. And do you have rescue potential post-transplant? Because these patients will be at extremely high risk for early graft dysfunction that could be rather significant. So this was a publication that many are probably familiar with in the Lancet, looking at ECMO for COVID infection. And I'm not going to belabor this too much, except to say of the people that they put on ECMO for ARDS, their major comorbidities were diabetes and obesity, something that I think many of us see in our cohorts, especially obesity. There were about 30% of their patients that had no other comorbidities. About 30% of patients had acute kidney injury. They had varying degrees of support prior to mechanical ventilation, but the majority of patients were on mechanical ventilation for 4 days before initiating ECMO, and a fair number, of course, had prone positioning and neuromuscular blockade pre-ECMO. And the number I'll highlight here is the in-hospital death was about 37% in the cohort. These are patients that were reported in the registry between January and May with follow-up to about August. So it still is an earlier time point in the pandemic, and we may see these numbers evolve. I can tell you institutionally, we don't do that well. We have a higher mortality than this in the patients we put on ECMO. And I think some of that is who you put on ECMO, how sick they are when you put them on ECMO, would they have recovered, or could you have salvaged them without ECMO? And obviously those are questions we can't answer. When you look at factors associated with mortality on ECMO, again, as you would suspect, age is a big driver here. Other drivers of mortality on ECMO or pre-ECMO cardiac arrest, chronic respiratory disease, and immunocompromised patients, as well as requiring VA ECMO. Now, again, those are some of the people we might not consider putting on ECMO to begin with. And when we put patients on ECMO for COVID primarily, we're putting them on as a chance at recovery and less at a chance at potential bridge to transplant. Now, that may come up in the future, but it's not generally the primary driver of the decision to use ECMO. And so, the question is, which of these patients should you put on ECMO, especially if you're resource limited in how many patients you can put on ECMO. These are transplants off of ECMO, so ECMO bridging to transplant out of UNOS registry data. And you can see if you look at the overall group, if you were bridged with ECMO, you do worse than if you're not bridged with ECMO. But that's really driven by low and moderate volume centers. And when you look at centers that are high transplant volume, greater than 50 transplants per year, you see there's not a significant difference between bridging patients with ECMO versus not. A lot of that is how good you are at ECMO, what sort of configuration do you use, can you keep your patients ambulatory, what patients do you choose to put on ECMO, but some of it is also likely related to your ability to salvage patients that may develop primary graft dysfunction post-transplant. This is data on the first 300 or so patients at Montefiore, so early in the pandemic. They weren't using much ECMO here at that point, 91% on mechanical ventilation. And I bring this study up only to show you that over half these patients died in the hospital, with somewhere under 50%, right around 48% or so, at least, not dying during their initial hospital stay. And what I'm getting at with this is again, I think that you're going to get separate groups of patients. You're going to get groups of patients that die relatively early in their mechanical ventilatory support or their ECMO support for whatever reason that might be. You're going to get patients that don't really get better, but have multiple other comorbidities or other reasons that they're not good transplant candidates. And you're going to get patients that are potentially going to get better, but you're not sure how long to wait to see if they get better. And then you can see how that will only leave a tiny group of patients maybe that are sick enough to need a transplant and not showing any signs that they'll recover, and that are otherwise a good transplant candidate. This is a little bit of data on radiographic follow-up on patients from China. These were not necessarily severely ill patients, but I bring it up to show you that 2/3 of these patients had full resolution of their CT radiographic findings within 4 weeks of leaving the hospital. This is a case report that was published in Lancet Respiratory Medicine of a patient that was PCR positive at the time of transplant. And that's why I bring up the question of, do you need to be PCR negative to consider transplant? This transplant occurred well into the disease course, 58 days post-presentation. So good reason to believe that there wasn't a lot of infectivity left and that you may be looking at really non-active virus in their PCR testing. They looked at that in other ways. The bottom line was this patient was successfully transplanted in Vienna, so eventually ended up having negative lavages and nasopharyngeal swabs for PCR, and at least we know lived to leave the ICU. And then I bring up this last slide to say that not every consideration for lung transplantation will be in the acute setting. It's possible that you initially recover from your illness and then begin to develop progressive fibrosis. I alluded to the heart-lung transplant that we did here at Vanderbilt. And that patient actually had progressive fibrosis after their initial hospitalization, where they were not actually that sick to begin with, sick enough to be hospitalized, sick enough to require oxygen, but then had progressive, development of fibrosis over the next several weeks. To be able to better capture COVID-19 related transplants, UNOS is adding COVID-19 related diagnosis codes. So starting next week, you can label, just like you can label your patient as having IPF or pulmonary hypertension or COPD, you'll be able to label them as having either COVID-19 ARDS, which is what we've spent most of our time talking about, or COVID-19 pulmonary fibrosis. And so what does ISHLT recommend? So the International Society of Heart and Lung Transplant recommends, and as you've seen, we base this on essentially no data. We base this on experience related to transplant and other forms of ARDS and what we think we might know about COVID at this point. But they also agree it's appropriate for a small minority of patients with COVID-19. They would proceed with listing for otherwise healthy patients with COVID-19 related respiratory failure if they're at least 28 days since the onset of severe lung injury, if they have a negative PCR, if it's single organ failure, so lung failure only, if they have good nutritional status and rehabilitation potential, and if other listing criteria and center policies are met. So no other contraindications to transplant that you standardly apply to your patients. And so with that, I've just created a jumbled mess of electric wires in terms of what to do with all this. But I do think that lung transplant only has a small role right now in COVID-associated ARDS. I think a lot of the patients are too sick, multiple comorbidities, age, multi-organ dysfunction, or they've had prolonged neuromuscular blockade, prolonged mechanical ventilation, prolonged heavy sedation, and have relatively poor rehab potential. I think another group of patients are bound to recover. And we need to allow sufficient time for that, because in the long run, you're better off with recovery in all likelihood than you are with lung transplant. We know that lung transplant, post-lung transplant survival still remains limited. We know that you're at high risk for primary graft dysfunction if you're transplanted in a bridge setting, and that may set your future in terms of earlier development of things like chronic rejection. I don't know what the appropriate amount of time to wait is. I think it's at least 6 weeks. Maybe you could convince me it's 4 weeks, but I think it's longer than what we think potentially. I'm not 100% convinced that you need a negative PCR, especially if you're well into your illness time frame and you may be able to get other markers of infectivity. I think you should be limited to large volume centers with sufficient bridging and rescue experience. And I think that, like anything else, our guidance around this will evolve with more time and experience. I don't think we know yet what the need is going to be for delayed transplant for progressive fibrosis after initial recovery from COVID-19. I think time will tell that. And like anything else, I think prevention is really still the best hope here, and that our overall need for using transplant for COVID-19 is going to be related to our ability to prevent infection and better manage disease to allow recovery. And so with that, I think that's all I have to say on the topic. I can certainly answer specific questions if appropriate now or later in the session.
Thank you. Someone asked in the chat whether you think it's necessary to do a viral culture if PCR is still positive before a lung transplant beyond 20 days.
The answer is I don't know. We actually still use the PCR negative approach because we're a little unsure whether you want to give PCR positive people a bunch of immune suppression in a transplant that you already know is less likely to succeed than a lot of the other sort of transplants that you do. And I don't know if Ramsey has an opinion. He's obviously a lot smarter than I am. So, but my opinion is that I don't know, but that we don't actually do it right now unless you're PCR negative, or we don't consider it unless you're PCR negative.
I would agree with Amit's comment about the PCR, not about being smarter than he is. But the rationale is, if you sort of step back and say, okay, we're going to take out these severely damaged lungs. If the virus is still present and is replicating, and we're going to put in new lungs, gee, what's going to happen, right? And we're going to give induction immunosuppression, et cetera. Now, the uncertainty and the unknown is whether the virus is still replicating or we're picking up a positive PCR from viral particles that are no longer replicating. And quite honestly, I don't know how you make that determination. So I think most of us have taken the position that you'd want to be in the sort of most conservative approach and require a negative PCR. I suppose if you had a culture and the culture was sensitive enough, if that was negative, that would probably answer the question. But these PCRs, unfortunately, are positive for an extended period of time. But if we're waiting 6 weeks or at least 4 weeks and longer, the PCR may well be negative. And so can you wait another week and until the PCR is negative and feel more confident that you're not going to infect the allograft? Probably can, and that seems more appropriate. Although I admit that the positive PCR may not necessarily reflect viral replication.
Thank you. We're going to move on to Dr. Nanad Maniar, who did his internal medicine residency at University of Louisville, and he's currently our chief fellow at Baylor, and he's going to present a case of COVID-19 in a lung transplant recipient.
All right, can you guys see my slides? Okay. Hey everyone, I'm Nanad. I'm going to talk about a patient that we had at our hospital who was a lung transplant recipient and got COVID-19 pneumonia. So the background is this is a 63-year-old male, bilateral lung transplant 2014 for IPF. It has a pretty good post-transplant course. Just calls in for a routine issue to the coordinator with nasal congestion and headache. Says he always has these things around changes of season and the weather, and so he gets a nasal decongestant. And this is on just the day that he calls. Literally the next day, his son calls in and says his dad is feeling short of breath, and they have a pulse oximeter, and his saturations are 70 to 80 on room air. So he's advised to call EMS and obviously go to the ER. So what we know from his history, besides the shortness of breath, he has some back pain, but no fevers and no known contacts, and his other systems are negative. As far as risk factors or just general past medical history, he has CKD3, he's hypertensive. And then after his transplant, he actually did have a VATS decortication on the left side for a recurrent exudative effusion. No known sick contacts, like I mentioned before. As far as his transplant history, he is CMV donor negative recipient positive. Like I said, was a recurrent effusion, and he did have right hemidiaphragm palsy from before. His home meds are tacrolimus, as you can see, Cellcept, prednisone. So he's on 3-drug immunosuppression, and he's on BOS prophylaxis with azithromycin, and then Bactrim for PJP. So when he first presents to the ER, he is afebrile, as stated. Blood pressure, heart rate are okay. And SATs are actually 91 to 95 on 3 liters nasal cannula. I don't unfortunately have his SATs on presentation on room air. His physical exam is just mildly tachypnic. Looks like he's working a little bit hard to breathe, but the complete sentences, breath sounds are okay, he's not wheezing, and the rest of the exam is normal. So as you can see, this is the chest x-ray on admission, and this is his baseline chest x-ray. So here you can see the graft. There is, as you can see, these patchy infiltrates in the lung here, and then maybe a little bit over here. And they were clearly not present on the baseline X-ray. He did not actually get a CT scan because he came to the ER and got labs done, and his COVID test was positive. The labs, as you can see, there's a little bit of a leukocytosis, and he does have the lymphopenia that was talked about a lot at the beginning of the pandemic. It's under 1,000. His renal function is close to his baseline of 1.88. And then the rest of the tests show normal heart function, normal troponin. And then the COVID-19 labs, as you can see, these are some of the ones that have been associated with COVID. And we've been checking them on a lot of our positive patients. The CRP is very high, but the dimer is just a little bit elevated, and the LDH is high. We didn't have a ferritin. And his tacrolimus level on admission was 5.3. So what happens as soon as he gets to the ER? So he gets presumptively treated for high-risk pneumonia with vancomycin. He is positive for COVID, like I mentioned. And then as soon as that comes back, he started on 6 milligrams of dexamethasone. He's given 1 dose of convalescent plasma, and he is started on remdesivir, which they got as an investigational agent because he was not a part of a trial. He gets admitted to an internal medicine floor, and then we get some more studies on him as we continue to treat him. So none of the other stuff really is very remarkable. As you can see, there's nothing on his sputum culture. The remainder of his viral panel is negative, and his echo shows a greater than 60% EF and normal RV size and function. He got a lower extremity duplex. As you can see, there was no clot on that. So I guess one question I was going to ask is, now that he is admitted, what would you do with his immune suppression?
Okay, so the polling numbers are still coming in, but it looks like most people opted for no change, and 10% said stop the tacrolimus, and 17% said stop the CellCept.
Okay. So as you can see, the poll results, like Dr. Kao said, looks like most people have said 74% would say make no change. And then just a few more have said stop MMF, and some of them have said stop FK. Sorry, I'm trying to close this poll screen now. Oops. Having some trouble getting this closed. Okay, sorry about that. All right, so now we'll talk about what happened once he was admitted. So we continued his tacrolimus. We actually did not continue the mycophenolate, and then the prednisone was held while he was on the dexamethasone. He was given DVT prophylaxis, a little bit more than what we normally give, at 0.5 milligrams per kilo twice a day. He did require 3 liters of oxygen, same as what he did in the ER, and he was advised to self-prone for 2 of the nights that he was admitted. After he completed his course of remdesivir, on day 5, his oxygen was down to 1.5 liters, and he was feeling subjectively better. And finally, he was discharged home on 2 liters of oxygen, asked to complete the remainder of the 5 days of dexamethasone by mouth, and followed up with clinic in a virtual visit. So first he calls his coordinator, after completing the dexamethasone, the prednisone is resumed. His room air sats are now up to 98%. And then we do a video visit in 2 weeks where he's feeling a lot better. He did have some thrush with dexamethasone, and then it kind of went away. And then he was told to restart his mycophenolate, but he had some GI issues, and so he resumed it at a lower dose. So here's some numbers. He did come back for a face-to-face visit at 4 weeks when we all felt comfortable that he had cleared the virus. Clinically, he was feeling stable. And as you can see, he has about 100 ml loss, close to, on his FEV1 in the immediate 4-week post-pneumonia follow-up. And he didn't actually do a 6-minute walk because he has some herniated disc problems and was having back pain. And then 2 months later, he comes in for another face-to-face visit, and sure enough, his FEV1 has returned to his baseline, and he's not quite there with his walk distance and needing a little bit of oxygen still with walking, but overall feeling a whole lot better. And he actually made plans to get that herniated disc repaired. He actually got a CT scan done as part of that visit as well, which I think happened to coincide with this like annual follow-up, and there was no residual scarring or any visible changes on his CT scan. So that was my presentation. Glad to report that this guy did very well actually in the scheme of things.
Thanks for that nice presentation. And finally, we're going to have Dr. Ramsey Hachem, who is the Tracy C. Marshall, Dr. Albert P. Trulock, Distinguished Professor of Medicine at Washington University, and he is the Medical Director of Lung Transplant at Washington University and Barnes Jewish Hospital. He did his residency at UT Southwestern, followed by a fellowship at Washington University. And he has a specific research interest in chronic lung allograft dysfunction. And he's going to talk to us today about the management of lung transplant recipients with COVID-19.
Great, thank you. Thank you, Nanad, for that very nice presentation. I have to apologize that I don't have any slides to share, but in truth, there really aren't good data that are worthy of being put on a slide. And so I'll try to summarize what I know and what's in the literature in terms of the management of lung transplant recipients who develop COVID-19. I think the most interesting finding has been that the number of patients who've had a lung transplant who've developed COVID-19 has been smaller than what we all were worried about in mid-March and early in the outbreak and the pandemic. I think a lot of centers and a lot of patients were very concerned that a lot more patients would get infected. But I think our patients are professionals at social distancing, wearing masks, washing their hands. And so those lessons that
I think he's frozen.
We seem to be having technical difficulties. Dr. Parulekar, do you want to chime in while Dr. Hachem is getting his connectivity back?
Not really, but if he had at least left me some slides, that'd have been nice. But no, so I think what he was talking about is that we perhaps haven't seen as much COVID-19 in lung transplant patients for sure as we thought we might see, largely related to the fact that they are already pretty good at social distancing, wearing a mask, washing their hands. A lot of them, almost to an extreme, don't leave their house and other things. And so, we haven't seen as much. In terms of what the outcomes might be, we don't have that much data. The largest groups of patients are certainly out of the New York area, with Columbia perhaps publishing the largest series. But what we know is if you're on immune suppression, or at least we think we know, not just in lung transplantation, that your outcomes may not be as good. The mortality rates might certainly be higher until we see more patients with the disease. It's going to be a little bit hard to tell. Anecdotally, we have a lot of patients that stay at home with their COVID-19. We've had a handful of patients that have had COVID-19 and haven't come to the hospital. Now, we have one patient that's been hospitalized with COVID-19, and they did have ARDS, and they were relatively early post-transplant. Probably hadn't fully recovered from the transplant yet, so I think I would have considered them to be at higher risk. They had more recently had a lot more immune suppression, and they ended up requiring ECMO bridging, which we were eventually, or sorry, ECMO salvage, which we were eventually able to decannulate, but then we're never able to fully recover from that hospitalization. But we've certainly seen people that have gotten sick and not been very sick at all and have gone home. In terms of hospitalized patients and how you manage them, I don't think there's necessarily a rule book or a playbook for how to manage hospitalized patients with COVID-19. We have stopped their cell cycle inhibitor or their anti-metabolites. So if they're on Imuran or mycophenolate, so azathioprine or mycophenolate, we typically stop that at diagnosis, and we would reinstitute it probably after recovery somewhere in the maybe 6 to 8 week range if they fully recover. We don't have great data to support that, but we think in the early infectious phase, when you're having high viral replication, it may be better to be on less immune suppression. We think in the hospitalized patients that are sick enough to be in the hospital, I think of they've been recently getting, of course, remdesivir, maybe convalescent plasma. Certainly in the patients that are in the ICU and have ARDS or respiratory failure, they've been getting dexamethasone.
Dr. Hachem has reappeared.
Yeah,
You
so
want to
is,
turn it over?
Would I like to turn it over? Sure. I would just I'll tell you where I left off. First of all, I filibustered for at least 5 minutes, and then after that, I talked a little bit about how the outcomes were probably worse in immunosuppressed patients, but we have lots of immunosuppressed patients that once they get the virus are not even hospitalized and end up staying at home. And I just moved on to how I would treat hospitalized patients. And I talked about holding anti-metabolites and cell cycle inhibitors early in the course of disease, although not having a lot of great data to support that or any data. And then otherwise treating them similar to how you would treat other hospitalized patients. And that's where I left off. Maybe you have other opinions, or certainly how you manage them after they recovered and what things you might worry about in terms of allograft dysfunction and other things.
I apologize. I don't know what happened, that I was kicked off my Zoom. But anyway, I assumed that Amit would read the names of the people in the Nashville telephone book to take up some time. But I'm glad you didn't do that and stayed on topic. I completely agree with what Amit said. It is almost surprising that outcomes have been as good as they have been in some patients, or in many patients, and many have not been hospitalized. Some have been hospitalized and have responded fairly well to the standard therapy that this patient received. Obviously, the standard therapy has evolved over the last few months with more liberal use and more widely available remdesivir and convalescent plasma. In terms of management of immunosuppression, I think holding the cell cycle inhibitor makes sense, although it remains unclear whether this lymphopenia is a predictor of poor outcomes, or if it's really a manifestation of the burden of disease and the burden of viral infection that is resulting in lymphopenia. And so lymphopenia is sort of a marker rather than an actual cause of poor outcomes. But I think holding the cell cycle inhibitor, certainly in the early period of the infection, is appropriate. I would not hold the calcineurin inhibitor, though. I think the risk of precipitating acute cellular rejection is probably too high to justify holding the calcineurin inhibitor during an infection. What has been interesting is that studies that have compared survival of solid organ transplant recipients to patients who were hospitalized with COVID-19 but were not solid organ transplant recipients have shown similar mortality or similar survival. Granted, those are short-term follow-up. There's a large multi-center study that was spearheaded by the University of Washington of a very large number of solid organ transplant recipients. And there were about 30 lung recipients in that cohort. And the 28-day mortality was about 20%. And that was similar to non-solid organ transplant recipients or patients. And that makes sense because the people that are being admitted with COVID-19 to the hospital are likely those that have comorbidities that increase the likelihood of more severe disease. Now, aside from the acute phase of the illness, there's a question of what's going to happen in the chronic phase. And is there a chronic phase of disease where these patients are more likely to develop CLAD in the 6 months or so after recovery? And there's obviously even less data for long-term outcomes among solid organ transplant recipients and lung transplant recipients in particular, mainly because we don't have many patients who are now 6 months post their COVID infection. For most patients that have survived, we're talking about weeks or maybe 2 to 3 months rather than 6 to 12 months. So that's something that I think all centers will be monitoring closely, that patients that recover from COVID-19 may be at higher risk of CLAD. What's going to be very challenging, I think, is if the numbers of infections continue to increase as they have been in the last few weeks, as we get into December, January, and so on. I worry that accessibility to pulmonary function labs is going to be more limited as it was in February, March, April. And if that's the case, it's going to be very difficult to know when patients are developing CLAD because they had COVID-19 in May, June of 2020. There's some reliance on microspirometry and home spirometry, and I think that's better than nothing. But we've seen a lot of inconsistent results with home spirometry. Virtual visits are helpful to be sure, but we don't have the, or we may not be in a position to have the tools that we have at our current disposal to monitor patients closely. So that's going to be a real challenge in the next few months. I'll stop here and I'm happy to answer any questions.
Yes, there are a few questions in the chat box. One question is whether you would recommend the use of antifibrotic agents in patients, I guess, with COVID-induced fibrosis prior to consideration of lung transplant.
I would not, to be honest. Obviously, it makes there's some sense to that question, but I would not. I think that if the patients are
Dr. Parulekar, looks like it's you again.
Dr. Hachem needs to pay his internet bill, but yeah, I mean, I agree. I basically agree with that. I think time will tell if there's a role for antifibrotics after COVID and which patients and what that role might be. I don't think we know that yet, and I wouldn't, advocate liberal use of them. Dr. Kao, you're on mute.
Sorry. Another question was balancing waiting 4 to 6 weeks for consideration of transplant with the risk for further organ dysfunction if you wait too long.
Yeah, I mean, that's a legitimate concern and one that we certainly don't have a firm answer for. But I think if you just, I think you have a lot of complications early and you do get some delayed complications, but I think once you've been able to support people for that amount of time, we've been able to continue supporting them. It's a question of whether they get better. I still think the risk-benefit ratio favors waiting longer for recovery than doing a transplant at 3 weeks, meaning I think you're going to, sure, you may pick out a handful of patients that would do better if you did that, but I think as a whole, I think waiting longer, you're going to transplant more of the right patients and avoid doing transplants in patients that may not benefit from it.
And then there is another question. I apologize, it's in Spanish. So I think it's whether you would get CT scans to assess for post-cap COVID damage in patients you're considering for lung transplant.
Yeah, we do. I mean, I think that if you already have a significant amount of fibrosis, that may aid in your decision making to a certain extent. Although I think you can get a lot of that data clinically, plus with time course, but there's not anyone we transplant that hasn't had a chest CT. So we do look at that. And I think that significant fibrosis is more concerning, probably.
Did anyone else have any additional questions? Okay, I would like to remind everyone to please complete the survey in order to claim CME. I would like to thank all of our speakers today. I apologize that Dr. Hachem's internet was not working quite right today. And the webinars are all available on the ATS website if you would like to review them. If that's it, then we will adjourn for tonight. Thank you. Thank you again to the ATS for organizing this.
Thanks, everyone.